Hey guys, I just wanted to review the last couple of weeks we had in lower quarter management on the hip. Um, we first started talking about intra-articular disorders. We discussed OA and FAA labral. Hip OA, unfortunately, is one of those conditions where we don't get to see it a lot. We tend to see people more after surgery for a total hip replacement than before. But if you get a chance to see folks with hip OA, the evidence is pretty clear that they can benefit, particularly from a good exercise program. Manual therapy in the literature, anyways, has seen some mixed results. But I think clinically speaking, you can really help people at least get their motion back with the manual therapy treatment, particularly things like the long axis distraction manipulation, maybe some belt work as well. And it's generally pretty well tolerated by folks with hip OA. And then the exercise program would be a combination of mobility, strengthening, and aerobic exercise. So this is probably an area where we need to do a little bit better marketing of our services, of what we can offer to these people, because I think we just don't tend to see enough patients with primary hip OA referred to PT. Most of them are told just to go ahead and wait for surgery until they can no longer really stand it anymore. So definitely a condition that we want to stay on top of. And then when we talk about younger folks with intra-articular, we're really talking about the FAI labral pathologies, and that's a current hot topic. The surgical rates for this condition have really exploded over the last 10 years. There's been some editorials in the literature that say this is maybe not justified, or the advances in surgical rates. The good thing is there's at least two, if not three, big randomized controlled trials that are ongoing right now to start looking at conservative versus surgery for this condition. Many patients come in, they get the imaging, they're told they have this problem, and then they're essentially told if they don't get it corrected, they're likely going to progress on to hip OA. We really don't have evidence one way or the other to say if that's true or not. So we probably need some longer term outcomes. The little evidence that there is out there suggests that we should at least attempt conservative management. And the management for things like FAI would be pretty similar to hip OA. Maybe do some manual therapy to try to get their pain down, get their motion under control. And then the mainstay would be a good exercise program working on strength and control around the hip, particularly if they have dysfunctional movement patterns that tend to sort of put that hip in a more closed pack position. In single leg activities, do they go into hip adduction, internal rotation, and kind of pinch down on the front of that hip? So once again, we need more evidence with this, but there's clearly enough out there that says we should at least attempt conservative management. However, similar to other conditions, once a patient's seen a surgeon, had the imaging, it's really hard to get that out of their head, and I think it almost makes our job harder. So hopefully we'll get some more answers over the next year or so to say, okay, maybe certain patients need to have surgery where others would benefit from conservative. To me, it sounds very similar to the shoulder impingement debate, where for a while a lot of patients were getting shoulder scopes, and now we're saying majority of patients can do well with conservative management with shoulder pathologies, even full rotator cuff tears. So I think we're probably going to see a similar thing happening in the hip, but that remains to be seen. And then finally, we talked about extra-articular hip disorders. We started with lateral hip pain, which is a really interesting disorder. When I came out of school, we often talked about that being a bursitis or an inflammatory condition. And now it seems like it's more related to a tendinopathy of the glute medius and minimus. The article by Grimaldi, I thought, did a really nice job with describing what their thought process was behind the etiology of the disorder and how that might play into your exercise selection and also your patient instruction in terms of avoiding the things that tend to compress that lateral hip area, such as activities placing the hip in greater degrees of hip adduction, standing on one leg, crossing your legs, sleeping even with the affected side on your side, with that top side up with the hip in adduction. And then the exercise selection, things like avoiding your piriformis and IT band stretching, even clamshells that are placing excessive compression or tension on that lateral side. Many of these patients coming in are women in their later 50s and older, and they likely are going to have a fair amount of weakness in that hip area. So you have to be careful with overloading them in the beginning. And I think a lot of you guys sort of mentioned that. I've certainly been guilty of that myself. So they recommend, low level loading, maybe isometric, or starting with double limb exercises or gravity eliminated exercises, and progressing over time as sort of the mainstay of treatment for these folks, is getting those hip abductors strong again. And then finally, we talked about athletic groin pain, which it sounds like you guys didn't have a ton of experience with. Another kind of hot topic in the area in sports medicine. There is a little bit of overlap between that and FAI. So with our patient that has groin pain, we'd certainly want to do like our Fader test to rule out intra-articular disorders, then look at like selective tissue tensioning, using manual muscle testing of the muscles around the hip, hip flexion, adduction, trunk flexion. All those muscles that insert into that groin or inguinal area can be involved. And as we discussed online, it might not matter exactly which muscles are involved because the treatment would be very similar. We're going to work on strengthening across that entire region, also looking at any dysfunctional movement patterns that might be playing into that, and trying to work on those as well. And that can be a really tricky area from a differential diagnosis standpoint. So think about ruling out lower back, pelvis, ruling out intra-articular, ruling in extra-articular as a way to do it. And don't worry too much if you can't figure out exactly which muscle is involved, because there tends to be a lot of overlap or multiple muscles involved. So great job, guys, on the last few weeks. From this week on, Heidi is going to be doing stuff on the knee. We have our weekend intensive coming up in the next few weeks, early November. Start to look at that case study, that patient narrative, and get a rough draft into your advisor for that. Any questions, please let me know.